Well, so subsequently, apart from the bigger figure of over 5,100, we also do know the situational report of how the cases are by regions. And you saw that of Greater Accra. Western North has 56, the Western region 52, Volta and Upper East with some 33 and 26 cases respectively. But we also do know there have been reported cases, at least Bono still has 1, Northeast 2, Northern region 16, the Upper West region 21, and OT with 24. And you look at the deaths so far and the recoveries, deaths of fatalities 22, and recoveries are in the number of 494. It speaks to the wider conversation about where these cases are located, where they were reported. Because if you look at what was the content of that news conference or interaction by the COVID team on Tuesday, focus on where we can locate the cases. It also means that the cases, because they are in the communities, need to be well identified, and we do know that the contact tracing team had been doing a lot of work. That's where we started the bigger conversation. Should we be worried? Because from the last press conference, now we have a wider picture of the many hotspots that have been identified by the COVID team and what needs to be done to make sure that everybody is on board. So Professor Eugene Marfo-Date is head Department of Population and Health, the University of Cape Coast, joining us on stream. And Dr. David Nanaije is a biostatistician also with the University of Ghana. Good morning to all of you. Can you all hear me? Professor Date as well as Dr. J.
Yes, I can hear you.
Yeah, great. Now, my first question, straight away we'll go to you, Professor Date. What did you make of the briefing yesterday from the COVID team in the first place?
Well, good morning, Roland, and I think I'm not the head of the department, I'm just a staff in the Department of Population and Health, just that correction. I think it's important we now understand what I call the geography of the pandemic in the country, because once we are very much aware of the hotspots, it will help with programming. We'll be able to design the appropriate programs to target these communities so that we can help fight the pandemic.
And to you, Doc, where do you think we have fallen short? If you look at now, we know that the community case counts and the hotspots seem to be closer to us here in Accra than we think.
All right, so good morning to your listeners once again. For me, yesterday's presentation was really exciting, and we have come to a point that I think as a country, we need to pat ourselves on the back for what we've been doing. Now, to go to your question, the next step that we need to move towards is to employ more of data science in terms of where we've gotten to. Now, the reason I'm bringing in data science is because all along as a country, all we've been doing is to identify those who have been exposed, do the contact tracing, also increasing the number of tests we've been doing. And this has been very efficient and very good for us. Now, as the numbers have increased, which is also a good thing for us as a country, because once you have the numbers, you have power to predict and to model. And what that will mean is that once we have the numbers and we can model and predict, it means that we have an opportunity to go in front of the virus, to know where it's going and what it's going to do now. So it's important that we consolidate our gains. Whatever we've been able to do is good. And I say a big thank you to all the biologists, all the frontliners, and what they've been able to do. But at this point, we need to move fast. We need to use the data that we've gotten, this rich data, to predict and model and check where we have to go and deal with this virus. And that is where I think we lack now, and that is the direction I will advocate for the nation to be heading towards.
Now, Professor Date, if you look at what perhaps the more developed countries have done, even though they have been overwhelmed with cases, is to try as much as possible to space out and try to get closer to their provinces or their regions or their communities to be able to detect. That has also brought to the fore a lot more cases. In our situation, because we've just zoned out Accra and the rest of the regions to be the main hotspots, does it mean that perhaps there's some level of concentration more on some others than the ones that perhaps don't have too many cases?
Well, I think, Roland, we need to appreciate the fact that cities and towns differ in their socio-demographic characteristics. So now that we're very much aware of where these hotspots are, we can figure out what the population size are, what the age distribution is, the education levels, the level of religiosity, the kind of work people engage in, and the sort of movement in and out of those communities, because these are all sort of drivers of the pandemic. These are drivers that make communities and individuals in these communities more vulnerable to the pandemic. Now that we have data on these, we can then look at what are the main drivers of this pandemic in here. And I would hazard a guess and look at about 3 main drivers of this pandemic, which for me are the population density of these areas, the kind of work people living in these areas do, and also to look at the sort of social interaction in these communities. Now, if you look at the list of communities that have been identified as hotspots, you realize that these are communities that have very dense populations. And population density in itself makes people vulnerable, because we've been told by the epidemiologists and the virologists that the virus spreads through human contact. And if you have a population density of, say, 5,530 in, say, Accra per square kilometer, and we have about 5,419 in Kumasi, then you realize that it is by no chance that these are the 2 key regions with very high numbers of cases. So with this knowledge, I believe that we can then, like my colleague said, we can then get in front of the virus. There are things we cannot change about our social structure immediately in the short term. Not possible, because these are built-up areas, but the question is that they are built-up areas in New York and other places. But what about the density is transmitting the virus? It's more to do with the sort of living arrangement people have in there. What is the household size, for instance? How formal or informal is the location? Are people able to stay and work from home? Or they will have to go out to make a living? Now, as people move, they move with the virus. Human beings are the vector in which the virus exists. So as people continue to move for work, to make a living, definitely we'll have the numbers going up. But it is our ability to contain the situation which will get us to succeed or fail as a country.
Dr. Naneja, you wanted to add something, but is it also now more imperative for us now to have many of you professionals in biostatistics and population, so that perhaps it gives us a deeper understanding of where the virus have moved to, and how perhaps we can better zone in and say we need to do the concentration, whether it's education or looking at public health in those areas?
Yeah, Roland, absolutely. So when you look at the map that you showed before we started this discussion, and now some weeks back, you could see that the hotspots, even though they hadn't been identified, were more or less located in Accra and then Kumasi and a few parts of Kaswa. But if you look at today's map, you could see that it's a fair spread, right? And that gives us more or less an accurate sampling process, which means that if you listen to what Dr. Data said, Prof. Data said, now we have the social mix and then the demographics of almost the whole country. Of course, we have about 2 or 3 regions that have not been affected yet, but this is a good mix. And that gives us a fair opportunity to be able to predict correctly, because now we have almost all the demographics and ingredients, if I may say in a layman's term, what we need to be able to do our prediction. Now, not all predictions are correct or accurate. You cannot really have it, but it's a margin of error. But once you have a good mix of the data, which is a fair sampling structure, and once you have the right tools, you'll be able to predict with some small margin of error, and that is what we need to move towards. we have the skills, we have the people available, and we need to open up and give the data to these people to help with the prediction. And once we are able to do that, that will give us an opportunity to be able to move a little bit faster. Now, the number is 5,000. We are doing all we can, and I think we are in the right direction. But you cannot sustain these numbers, because as the numbers move up, they eat into your system. You have to quarantine people. Do you have enough? Do you have enough PPEs? So you cannot hold on to this for long, and therefore you need to move up the system and try to be there before the virus gets there, and that will help. One quick thing I also want to ask is for us to improve on the rate of recoveries, because as the rate of recoveries improve, then the stress on our health system will also be coming down. So, for instance, if about 50% of the people that we find positive are improving or getting treated, then it means the stress on our system is also lowered, and then we can be matching the virus good to good, and then we'll be able to deal with this virus.
Okay, so I'll pose this question to the two of you. And first, I start with Prof. Date. If you look at, from your observational standpoint, what a strategy is now, what do you think it is?
Well, I think we're going about the testing, the tracing, diagnosis, and the isolation. And I think it's working perfectly. But I think we need to move to a level where we targeting people with messages that will bring about changes in their behavior. So because we need to appreciate the fact that we're trying to change a certain system. We are a country that is multi-family. We are a country that has, we have a certain level of social interaction which cannot be wished away in a day. But the most important thing is that we need to put in place a deliberate effort of communicating about COVID. Education is okay, but we need to move the education to a point where we're getting what we call social, and we need to do what we call social and behavior change communication. Yes, we need to interface the biologists, the epidemiologists, the public health experts, and the communicators. What we've done so far is provide education, but the question is that who is our public? Do we know who we're communicating these messages to? Do we have a clear target in mind? In communication, there's not like a general population, because different people have different concerns, they have different aspirations, and they have different belief systems. People have different levels of risk perception. Now we need to appreciate all these publics and try to put in place communication materials and messages that will target each and every one of these publics. If we look at them as a homogeneous population called Ghanaians who we can communicate to, we might be failing the fight when it comes to communication and trying to change those behaviors. We need to go to the point where we'll have very well segmented publics and target them with messages that will bring about changes in their behavior, that will bring about changes in their attitudes. So we need to have a sort of a holistic view. The Ghana Health Service and its stakeholders are doing a great job. But I think it's about time we have a very multi-sectorial approach to doing these things, where we'll bring all sorts of people on board to help with this fight against the pandemic.
Right, so I will also want to approach this in what I call the 3 R's. So we need the right data, right science, and then right attitude. In terms of right data, what I want Ghanaians to do is that if you test positive and then they are asking for information to help the tracing, try and be as candid as you can be. Because if you give the right data, that will feed into how we can do our modeling and do all the predictions. Now, if you live in a community that you know somebody that is showing some of these symptoms, you need to be quick about it, provide the right information to the right source. We have the phone numbers that we can do. Now, in terms of the right science, what I would want to advocate is that we need to, as Prof said, we need to bring on board all the expertise that we have. This is the time that we need to approach this in a multi-sectorial manner so that everybody will contribute his or her quota for us to deal with this virus. Now, the last R is the right attitude. The right attitude has to do with all of us in terms of what we've been told to do, put on your face masks, social distancing. These things are difficult to do. They've not been part of our everyday life because of the kind of social structure that we have built as a country. But this is serious. This is a way that we can deal with this virus. And it's almost, let me say, it's almost free. Once you have your nose mask, social distance, what do you need? All you need is the right attitude. So Ghanaians, we should all try to put in the right attitude. We should not say that this thing is not going to do anything to us. We need to deal with this. In terms of our culture, in terms of our religion also, it's fine. We have to deal with it. But we need to look at how to approach this in a science-based manner. And I think once we apply these 3 hours, we'll be able to deal with this virus.
I have to stay with you, Naneje. If you take a look at what the extrapolations are in the West, they're able to tell you which minority groupings, which groupings within the demographics are most affected, whether by fatalities or first-time infection recoveries and all that. Is it now time for us to start doing that?
Absolutely, absolutely. This is the right time for us to do that. So if you look at what the Ghana Health Service has been providing, it's a process. We've been moving along, but this is the time that we need to break the data into those portions, and that will help us. Don't forget we are disadvantaged because of the kind of resources that we have, and therefore we cannot go testing, screening the whole country. This is the time we do targeted approach in terms of the interventions. So once we know the demographics, let me take the last establishment that we had this high infections, the industrial area. Now, that gives us an insight. 1,500 plus, and about 500 of them got infected. That gives us about 30%. That tells us that in Ghana, when we talk about confined establishment, we know that possibly, give or take, we have about 30% infection rate when you talk about establishment like banks, markets. These numbers speak to us, they give us insights, and therefore we need to start bringing them up into those portions. And that will give us a fair idea of where to target, because we don't have the resources, we don't have the time. A typical example is that contact tracing. We are entering, or we are already in the raining season. This is going to slow down the contact tracing. If it rains the whole day and then you have to trace somebody, it's going to slow you down. So we need to use these numbers and do a targeted approach, and that will help us in terms of the cost, in terms of the timing, and then we'll be able to deal with this virus.
Okay, let me give you the last word, Professor Dotte. Now, moving on to the next step is that we need to keep these demographic data and the extrapolations out there. But how would it help these publics or these groupings to be well aware of their health?
Well, I think that it's important. Like we have the data. Now, as Nana said, once we have the data, now we need to break up the data into finer details.
Okay.
We know that majority of the cases are coming from workplaces. What are these workplaces? Who are these individuals who are having? Now, you're looking at the locations that we have for Ashanti region, I think it's coming from Obuasi. What happens in Obuasi? From Greater Accra, where are the numbers coming from? Now, with this appreciation, the next level is to get people to change their behavior. There are protocols we need to observe, but people will not observe these protocols just like that because they have a certain behavior. If you're telling me to wear nose masks, what am I losing? There's an opportunity cost for wearing the nose mask. But how do you get me to appreciate the fact that to wear the nose mask, I'm not saving somebody else's life, but I'm saving my life. So in trying to change people's behavior, you need to communicate the benefit to these people. What benefit is in there for me if I wear the nose mask? What are the benefits that I will derive if I decide to wash my hands regularly? Now, to get all these things working also, we need to also look at how to target people's minds and their hearts. But in doing this, we should ensure that we don't elicit negative emotions, because negative emotions will give us stigma. We need to look at this whole process of communication about COVID and to move it from a point where we're just giving people education to a point where we are changing people's behavior. These protocols, are people abiding by them? Do we need to begin to enforce them?
Yeah.
What do we need? So we need to be we need to have a very effective and aggressive communication campaign. I think, as of now, I'm not seeing that. There are a few messages in here, there are a few text messages we get from time to time, but this is the time we need to use communication as a tool to target this virus, because it's a social thing. People's behaviors must change. There are things we cannot change in the short term, but there are things also we can change in the short term.
Okay.
Can we get all the people communicating about the virus doing the very things they are asking people to do?
All right. Well, we have to end the discussion. And thank you very much. It's been very insightful. And I know that we will broaden these subjects subsequently on other programming on the channel. Professor Eugene Marfo Date, Department of Population and Health, the University of Cape was helping us there. And alongside, we had a biostatistician from the University of Ghana. And Dr. David Nana Ejay also helped us. And I have to say good morning to the two of you. I wish you well for the rest of the day. But in the meantime, also good morning, Dr. Samuel Esiambedu, also of the University of Cape Coast, and helping us over the period. But let's take a break. When we come back, Akese Brimpong is right here.